What if decline isn't just happening to you, it's being done to you? Quietly, chemically, by the very prescription sitting on your nightstand right now. Last video, I made you a promise. The specific drug classes where age dosing mismatch hits hardest after 60. Today, every promise gets kept, starting in 60 seconds. But first, one term. Write it down. Iatrogenic aging. It means symptoms of decline caused not by age, but by medication behaving differently inside an older body. Once you understand which drugs trigger it most, everything you've accepted as normal gets questioned. Everything. Stay with me, because the first name is coming right now.
Before the first reveal, 4 things to hold. 1. There's a medication taken by millions of seniors every single night, considered so routine nobody questions it, and it carries one of the worst clearance problems after 60. 2. The second drug class protects your heart, but after 60, it may be quietly crossing a barrier it was never supposed to cross. 3. There's a 3-symptom combination that gets diagnosed as early dementia constantly, when the real cause is a medication list nobody ever added up. And 4, before this ends, 3 words, just 3, that permanently change every doctor's appointment you'll ever have. All 4 coming. But the first drug name, right now.
Benzodiazepines, Xanax, Valium, Ativan. Prescribed for anxiety, sleep, muscle tension, often refilled for years without a single reassessment. After 60, the half-life of these medications can double. A drug designed to clear in 8 hours now lingers for 16, sometimes longer. That looks like fatigue sleep can't fix, balance problems nobody connects to a pill taken the night before, a mental slowness everyone accepts as inevitable. And here's the number that should have changed prescribing habits years ago. Falls are the leading cause of injury-related death in adults over 65, and benzodiazepine use is one of the most consistently identified contributors. There's a publicly available document flagging this exact risk. Most patients have never heard of it. Search Beer's criteria. Tonight.
Now, loop 1. The medication's so routine that questioning it feels almost strange. Z drugs. Zolpidem, Ambien, Azopiclone, Lunesta. Taken nightly by millions, assumed to be the gentler, safer option. Here's what the label never mentions. In adults over 65, Zolpidem clears up to 45% more slowly. The FDA issued a specific warning, recommending the starting dose for older women be cut in half. That warning was published. In many practices, prescribing habits never followed. So the medication taken every night to improve sleep may still be chemically active the following afternoon, silently producing the exact fatigue and fog the patient is blaming entirely on age. Loop 1, closed. But here's where it gets more complicated.
A medication causes a side effect. A side effect gets treated with a new prescription. The original cause stays completely untouched underneath. That's a prescribing cascade, and it's invisible by design. The cardiologist sees their piece. The urologist sees theirs. The GP sees something else. Nobody owns the full picture. In clinical observations, the professional most likely to catch this pattern isn't the specialist. It's the pharmacist, because they see every bottle. Your action. Ask your pharmacist, not just your doctor, for a complete medication system review. Now, the second drug class. The one that genuinely surprises people. Because this one is associated with protecting the aging brain, not affecting it. And yet, after 60, something shifts.
Lipophilic statins, Lipitor, Zocor. Cardiovascular benefits are real, documented, and significant. But here's what changes after 60 that almost nobody explains. The blood-brain barrier becomes more permeable with age. Lipophilic statins are chemically designed to cross fat-based membranes. As that barrier loosens, more compound reaches brain tissue than was ever intended. In some patients, cognitive dulling, unusual muscle fatigue, emotional flatness, all quietly filed under aging. But the timing, when those symptoms began relative to when the prescription started, often tells a completely different story. Now, the hidden cause that ties everything together, the one no single specialist ever calculates, and the 3-symptom combination I promised, the one misread as dementia, that's next.
Anticholinergic burden. Many common medications partially block acetylcholine, the neurotransmitter central to memory and attention. Benadryl, bladder medications like Ditropan, certain older antidepressants. Each one, alone, seems minor, but the body experiences the total, not the individual. When that total climbs across multiple prescriptions, managed by multiple specialists who never see the complete picture, the cumulative effect can score on a standard cognitive test as early dementia. Now the 3 symptoms I promised: unexplained cognitive slowness, fatigue that full sleep never resolves, and emotional flatness, a sense of watching your own life from slightly outside it. That triad in someone over 60 on multiple medications is not an aging diagnosis. It is a medication question.
Robert, 71, retired engineer, his entire identity built on precise, structured thinking. After 70, sentences left unfinished, tools misplaced, group conversations impossible to follow. His family began exchanging those quiet looks. His physician ordered cognitive testing. The word decline entered the room. Nobody, until a pharmacist reviewed his complete list, had looked at his 6 prescriptions as a single system. 3 carried anticholinergic properties, none flagged individually. Combined, measurably suppressing his cognitive function. 2 medications carefully adjusted, and Robert described what followed in exactly 2 words. I came back. Not better, not improved, back. His family had been preparing for a diagnosis that didn't exist. Which brings me to the 3 words I promised you. Dose, duration, alternatives. Before leaving any appointment, any medication, new or existing, ask all 3. Dose. Was this amount specifically studied for adults my age or carried forward from a younger baseline? Duration. When was it last evaluated whether I still need this, at this strength? Alternatives. Are there options with lower anticholinergic burden or a shorter half-life that achieve the same result? Write those 3 words on a Post-it. Bring it to your next appointment. You don't need a medical degree. You need the understanding that the prescription was written for who you were, and it may be time to update it for who you are. That's not giving up on medication. That's demanding it be accurate.